Hello, I'm Dr. Andy Frankenberger, and thank you for joining me for the second of my mini lecturettes. This is a talk I gave at the Sports Surgery Clinic Return to Play conference a week or two ago about the use of 3D motion capture in the return to play setting. First of all, I'd like to take you on a little journey through 2 or 3 papers. The first one here is Con's paper in Sports Medicine, and for those of you that aren't aware, Sports Medicine is a nice journal which primarily looks at review papers, and this is a review looking at the injury incidence of mainly Australian rules football, but focusing on the available studies that are there to date. And one of the things that really strikes home about this paper is the fact that most of the modifiable risk factors identified really look at a single joint. In particular, looking at knee flexion and extension strength ratios, which focus on 60% as being a figure under which the injury risk is increased, but also focus on the high eccentric loading at the terminal swing of the leg, focusing on the knee. Interestingly, he found that there were no papers showing any association with a lack of flexibility as one of the mechanisms of injury causation, but did find a number of papers that demonstrated low apparent flexibility of the hip flexor and quadriceps muscles being independent risk factors. Again, these are really focusing on a single joint rather than looking at the body as a whole, or indeed movement as a whole, and really emphasize where much of the research in this area is dated. Other studies talk about stiffness and the rate of lengthening versus strain, although they really have no means of quantifying it. And finally, ankle dorsiflexion was chosen as a potential risk factor. But really, sport is more complex than this, and it's not just one thing, one factor or one joint range of motion or one strength about a joint that really is likely to be the causation of it, and we'll explore that shortly. And this is primarily given for strength and conditioning coaches, and this paper is a very exciting one for many, again from sports medicine, looking at the development, retention and decay rates of strength, comparing union, league and American football. No Aussie rules here. There are 27 papers in the systematic review, and it used a nice concept of taking a value for comparing studies of intensity relative to volume, and it used that to be able to compare the percentage of 1 rep max multiplied by the set multiplied by reps, because otherwise the studies themselves are very difficult to compare. Now look, this study doesn't really give any new information that you're not already aware of. For strength gains, they found that a composite study showed 3 sets of 6 to 9 reps at 77% demonstrated the largest gains, and for power it was an average of 4.3 sets of 7 reps at 81% of 1 RM. But really the focus I want to look at here is the decay rate, and they found that 1 to 2 sessions of a week of strength training was enough to prevent decay, but that you can go 8 weeks without. And so the previous study looks at strength or weakness or relative weight ratio as a means of identifying injury, but then this study is demonstrating that for 8 weeks you can go without really losing any main gains in strength, and as such, can it really be as important? There are some fantastic papers really focusing on hamstring strain, and David Opal, really working out of Brisbane, has really been the forefront of many of these papers. Again, though, the focus really is on the testing and training of a single joint range with a fixed pelvis and knee flexion and extension, and that, although clearly is nice to be measurable and nice to identify as a single factor and something we're all after in terms of an identifiable and easily intervened factor affecting injury, it's really, I don't believe, quite as simple. David's going on to develop a hamstring strength testing machine, and that paper I've discussed in my research review before, and again it's focused really on singular movement, much like Carl Askling's H-test, and I think we're missing a trick. What I'd like you to do is indulge yourselves in watching the summary of clip coming up now, and instead of enjoying the rugby and sports within it, what I'd like you to do is look at the pelvis, and look at the pelvis relative to the ground. I really think we're missing the trick here, and I think the pelvis stability is the critical factor in much of this multi-joint, multi-directional movement with force, power generation and stability. Take a look for yourselves. Running in the same direction. Fantastic, nice hard start. Jackson with support. Checks his kick. Now then, whilst many of you won't be quite as sad as I was that Melbourne Storm went in the grand final this year, I think looking at Billy Slater, the athlete in the last clip there, one can really see the need for that ability to look at multi-directional load across the pelvis rather than just the interaction with the ground. And that leads us on really to what is 3D? What is 3D motion capture? It's a question we're asked very often. We're leading a large research program into athletic groin, hamstring and ACL rehabilitation at present. And what is 3D? Look, what it is not is this. It's not a set of stickman images in multicolour demonstrating really little in the way of hard data. What we do to obtain this data is use bony landmarks across the athlete and place on a number of reflective balls. These balls themselves are localised in time and place, but also in 3 dimensions, in X, Y and Z dimensions, by a series of infrared cameras. The software is the clever part, and it reassembles the person knowing where those predetermined anatomical markers are. And this allows us to reconstruct the lower limb based on segments of the thigh, the shank, the foot, the pelvis and the torso. We collect motion capture data at 200 Hz and force data from the force plates embedded in the sports turf floor at 1000 Hz. And this enables us to reconstruct the exact movement for which we're producing a challenge test. Now, any test is only as good as its validity, and really that's what we're working on at present. But if we take back to a singular joint in a single moment in time, just here in the ankle joint as we press off the force plate in a turn, you can see on that chart to your right that you're dividing the force component in that ankle into 3 movements, to the x-axis, the y-axis and the z-axis across time, and we can see how the pressure, the force changes and the moment of the ankle movement. If you can imagine that for every joint and being able to capture it, you can see very quickly that we'd have over hundreds of thousands of data points, and the ability to actually define the point either at peak knee flexion or maximal force is very important without us creating multiple layers of force. This nice summary diagram by Linthorne really explains to you how the ground reaction force, and this is the kinetics, this is the force change of a counter movement jump. You can see here in the first line that the man is standing, the subject is standing. As he dips, you can see the ground reaction force decreases. It increases rapidly to the point D, correlating with the movement off the ground. And then as the subject leaves the ground, you can see there's no ground reaction force, but as the subject regains the ground in H, there's a significant spike in ground reaction force there. So that really explains what you're looking at, but in a singular direction. If you now imagine X, Y and Z component being applied to each joint up the chain, you can see the detail which we can look at this with. And it's not just the stickman images. This is a summary chart of one of our tests that we'll go on to talk about later. So what I'd like you to do over the next 10 minutes or so is take you through some papers which really are starting to demonstrate where performance and where indications may lie for the use of three-dimensional motion capture and return to play. The first paper I'd like to look at in the Journal on Strength of Conditioning by VICON. It looks at the long-term strength training effects on change of direction sprint performance. This is an interesting study as it looks at soccer players in three distinct age ranges, but in specific nature and looking at the change of direction. We know in soccer sprints usually are maximal about 30 meters, but most more than 50% or less than 10 meters. Many studies have looked at non-compound lifts, including hamstring curls and knee extensions as the intervention, which really don't apply to the movement skills we're trying to learn. But this study set out to look at whether there was a strength training effect in change of direction. It took 100 subjects over a 2-year program and gave a periodized strength program to those individuals. There were 3 broad groups of under 10s, under 19s, under 17s and under 15s, with a control group of senior players. Each group had 3 soccer sessions and 2 strength. And in each strength session, there was a back squat in one of them and a front squat in another, along with bench and standing row and some core stability. Initially, the periodization of the program gave 5 sets of 10 reps, and then later on, as the conditioning became evident, they had 5 sets of 4 reps. What's interesting about the study is the discussion on which return to play or which change of direction sprint test they were. We know there are some Illinois and T-test, but they do not easily differentiate between the left and right. And this study was interesting, and so it designed its own intervention, which was a 5-meter triangle test. As you can see from this slide, participants started midway down a 5-meter limb, raced to a point, changed about a 60-degree angle, and raced round to complete the loop, making 2 complete turns. The test was performed in both directions, which is really interesting because it looks at the dominant versus the non-dominant leg. How do you quantify this, though, in terms of intervention? Well, look, you can see here below the line the changes in the change of direction speed for the left and the right leg for those who'd undergone a strength training program versus those who hadn't. And this was uniform across all 3 age brackets, so it's not so much an age-specific effect, and the effect actually became greater the older the players became. What you can also see there is that in the control group and in the intervention group, that the differences were more marked after 2 turns rather than 1. So what does this study tell us? Well, look, in our view, in trying to design reproducible change of direction tests and apply 3D motion capture, that this test would appear to be a valid test to use. Moving on to another paper here, in Clinical Biomechanics, talks about the anticipatory effects of anterior cruciate ligament loading during sidestep cutting. We know what the sidestep is. It's actually very difficult to recreate, but we know it puts the knee into valgus and extension, making the hamstring load maximal along with the ACL. It's difficult to reproduce in the lab, though, and these researchers gave us some great clues. They wanted to recreate a 40 or 50-degree cutting angle, but needed to create some degree of indecision, and so gave the subject an angle of attack running towards a force plate, but gave them 3 trigger options. One which was an arrow saying stop, one an arrow saying cut left, and another saying continue on. And so the subject had no decision-making process before the anticipatory movement. So he looked at 3D data, EMG and ground reaction force. I guess where it fell down, it took 20 recreationally active but untrained female athletes. But interestingly, they would compare the load on the ACL, and we can see here, primarily in the sagittal plane, the difference between the anticipation load and the unanticipation load in the ACL. Now, what does this tell us in terms of changing movement? We still have to have unanticipated movements in sport. That's what the beauty of it, and it's where really we can improve performance. But what it really showed is the next graph. And if you look there at the center, the hip adduction, you can see the significant difference in the anticipation versus the anticipated movement. if we can focus on this in terms of the speed of muscle recruitment, in terms of controlling that hip adduction, and even in the hip flexion and hip rotation moment, therefore training the movement, we can improve both performance in decision and potentially reduce the risk of injury, both critical factors in terms of return to play. Moving on here now, we've got a great subject, but we're back to one joint. Again, this study by Brown looks at the association between the lower limb muscle activation strategy and result multiplanar knee kinetics during single leg landing. What did it do? Well, look, it took 35 female athletes in high-risk landing sports of volleyball and basketball, and it looked at them with 3D, EMG and ground reaction force. And what it really was trying to identify was what happened in the muscle activity in a predetermined side hurdle hop. We know that the side hurdle hop creates an imbalance in terms of hamstring and quad activity, but also needs significant glute activity in order to stabilize it. And in this study, they jumped over a 17 centimeter hurdle hop and noticed greater reactivity of the rec, which was predicted, but it increased the anterior tibial shear force. But there was no reactivity parameters, were actual predictors. And so this suggests in a predetermined study group, the forces increase, as you can see here, by the relative reactions of the muscle groups. There's little to learn in that. Although as a test itself, it's challenging both in terms of the coordination of the hamstring medial to lateral and medial to lateral activation. Taking that step, one of the papers I've read this year in clinical biomechanics is by Stringer, which looked at the comparison of glute and hamstring activity in 5 commonly used exercises. When we were thinking about our 3D work, we tried to decide whether a forward or a side hop was really more challenging in terms of glute activity, and suggested to ourselves that a side hop, given the fact that you'd have to control for Trendelenburg and glute med activity, would probably be the most complicated. We know peak knee valgus contributes to ACL re-injury, and also the rotational torque force can contribute to hamstring injury, and the gluteals oppose this. One thing to remember here, though, is dynamic tasks are not maximal strength tasks, so power rate and power production is important, but maximal strength, commonly tested in many of those return to play criteria, really may be less important. This study took 41 subjects, half male, half female, 3 sessions training a week, although they were not elite athletes, and looked at the EMG activation patterns. This is very interesting. In the white boxes here, if you look to the left of each of these graphs, that looks at the double leg sagittal hop. The second box is the frontal plane hurdle hop. The third, the 180-degree jump. The next, the single leg sagittal. And finally, the split squat. So you can see from here, in terms of muscle activation, the sagittal jump, if we move to the right-hand side of these bar charts, on a single leg, was greater in the frontal plane rather than the sagittal, which was not what we'd expected. Equally, if we look at the top line here, you can see that their medial hamstring was greater than the lateral, which was clearly activating to limit rotational control of the leg. Now, there are some study limitations here. These were untrained subjects, and so intervening, they'll have a very rapid learning effect. But still, it's an exciting differential, and one that demonstrates where we can try to improve that pelvic plane control. 2 more papers to discuss, and this one's from Japan, looking at elite basketball players. It took 28 female basketballers and asked them to complete quite a specific task. You can see here the basketballer to the left of your screen. She was asked to start behind the line, and the line was set from the force plate by her height. She was to move laterally to touch the force plate, make contact, and come back behind the line as fast as possible. And these researchers found something interesting, which is summarized in that diagram. The biggest single factor was the change in the video vector, or the resultant force in the ankle from the center of mass. Section A at the top of the graph shows that the more acute that angle, and the lower the center of mass, the more rapid the return. The second the video vector of that change of direction came outside the center of mass, there was torso rotation and slowness. Again, these are identifiable by 3D biomechanics, but also, more importantly, can be added in a return to play program, improving performance and minimizing the risk of rotational groin injury. And finally, just to whet your appetite, a fantastic paper in PLOS by the French team, talking about the detection, deception in movement, and the sidestep. Now, this study is relatively complicated, but what I want you to take from it really is that what they found was the ability of elite players to be able to use the feinting maneuver with their head and upper torso whilst maintaining pelvic stability and that centre of mass foot position. This is a skill which is part learnt in time, but the novice players, whilst trying to feint, would use their torso and use their pelvis and indeed create a larger arc which was slower, making the change of direction of the rapid movement virtually impossible. Now, this study was fantastic. It used not only 3D kinematics but also a virtual reality headset, creating the scenarios so they were reproducible in both novice and elite athletes. Something really to take home in terms of where we can use the kinematics in applying both the performance advantage rather than just return play. If we move on to groin pain and athletic groin pain for a second, we can see that there are significant numbers of studies comparing strength, adductor to abductor strength, which has really been since Holmick wrote the fantastic entities paper in the American Journal and the BJSM. Garrett talks of the imbalance between the propulsive and stabilizing muscles of the hip. Mayers talks between the load transfer from torso to pelvis. All of these things really contributing to that rotational and anterior and posterior pelvic stability. If you think back to the videos we watched earlier on, the pelvis has to move, but equally, the pelvis is the source of much of power production of the gluteals, the extensors, and the flexors. Can it be that we're looking at a single plane of abductor versus adductor, or flexion versus extension? Or do we need to start to look at all of these things together? Things to remember here is from this great study looking at relative forces, you can see the dotted line at the bottom as the ground reaction force, the vertical joint force through the gait cycle, but the muscle forces are almost 3 times higher. So we're not talking about small forces if the pelvic stability is not there in terms of acceleration, deceleration. Much of this force can be wasted or abnormally used. And you can start to get an idea of where the progression of the tension in the muscle and the potential damage of soft tissue injuries is. This next study, Dolstra, in the Journal of Biomechanics back in 1995, shows your pelvis. The posterior area there is where the gluteal muscles attach, and you can see the acetabulum, where the force, the main load through mid-stance goes. And you can see in groin pain that this passes anterior into the superior pubic ramus. We talk about pubic bone edema as being the pathology within anterior groin pain. But one has to assume that there is an overload, a pelvic biomechanical overload, which causes this to progress from normal load transfer to bone edema and bone stress response. If you flex anatomy of the groin here, you can see that anterior sling of the rectus abdominis running round into adductor longus. In the small inset picture, you can see how that's one singular aponeurosis, with a relatively small aponeurosis of the oblique muscles and transversus joining it in almost a Y shape. Much of the talk about sportsman's hernia focuses on that small oblique aponeurosis, whereas one can see the adductor and rectus aponeurosis, significant player. It takes only a small anterior pelvic tilt to overload that structure, and you can understand now why maintaining that pelvic stability is so important. Let's go on to the tests that we're doing in both our research and our normal clinical rehabilitation with groin patients. The first test is a take on that earlier paper in terms of a 5-meter triangle test. This is a decision cut. We'll play it here, and you can see this athlete runs forward up to the corner, cuts, and this final cut is the force plate in the ground. And we're able to recreate that reproducibly from our right and left side. But as you've seen, we need to introduce some indecision. In this next test, the subject's asked to run towards the defender. The light gates will then trigger us to tell him to stop or to cut to the right, and we reproduce this in order to see whether we can create a higher level of neuromuscular load. Many of the basic tests we're really using to try to correlate with existing work. The single leg squat you'll all be very familiar with. We choose to do this in an uninstructed way, but you can see there the difficulties in pelvic stability rather than just the knee varus valgus. If we play that again and you have another opportunity to watch, you can see how much different the 2D video image there is compared to the rotational image, you can see really exposing some of the potentially causative mechanisms. Now, of course, we don't know whether these correlate with injury as yet, and that's a prospective study still to do. Next test is familiar to many of those who have looked at ACL studies, and this step-down test is very reliable in terms of putting a highest level of load over the knee. But you can see there, in terms of the pelvis and the femur, the rotational forces are far more interesting than just the knee in isolation. Again, we'll watch that again. But another ability to look and see the difference. Now remember, this is not about those 3D stickman images, but what you're actually looking at here is the ability to compare the data that we have versus video. We talked earlier about the side hurdle. We've used a 15 centimeter here in order to look specifically at the ability for the glute and the medial hamstring to activate both before and after, really trying to simulate a sidestep. The difficulties, of course, with any of this research is the ability to reproduce accurately the tests so that we've got benchmarks of normative data. But you can see there that certainly puts a high load in movement, and we plan to repeat it again in a forward movement. And moving on, you've seen the cut already, we'll not go through that again. In terms of the change of direction, the planting, you can see the force going through the pelvis there in terms of trying to recreate what we're asking the patients to do. So can we correct some abnormalities? Well, look, in the groin pain program so far, we've identified that there are 3 key areas of correction. Here you can see in this patient a lack of torso control in the turn. Play it in slow motion so you can look, but as he plants his foot there in order to turn, his torso continues to move in the direction of travel rather than turning towards the direction of intended new travel. And that delay provides a rotational oblique force on the pubic bone, combined with an anterior pelvic tilt. You can see there, as you replay the video vector arrow, demonstrating that the force drops outside of his center of mass, similar to that previous study you saw in basketballers, creating a shear force. The next issue here is in terms of pelvic obliquity and the ability to stabilize that pelvis relative to the ground. And you can see in this clip, again, as the athlete reaches the force plate, he plants, the pelvis collapses. He does keep the center of mass within the video vector, although you can see the delay and that rotational force, all as mechanisms showing poor rehabilitation. Where are we taking this? Well, we're working currently with Dublin City University and the Clarity Centre for Sensor Web Technologies, really to try to develop structure for the future, trying to take the 3D biomechanical laboratory out into the field to apply these directly to return to play. We have a lot of work to do in that. So far, the difficulties of reproducing these tests and proving their use in rehabilitation is a number of years away, but we're working to do that. The most important thing about this talk really is the acknowledgements. My colleague Dr. Anna Farvey, who I started a research partnership with in Melbourne University many years ago, and really has been critical in both the understanding of this but also in directing the program. Our research and rehab team there in the next block, and also our rehabilitation program is led by Enda King, one of the most exciting physiotherapists to work with. An enormous research team, and they're advised by Dr. Siobhan Strike from Roehampton University, London, and also Dr. Kieran Moran from Dublin City University. But this project wouldn't go ahead without Mr. Ray Moran, the clinical director of the Sports Surgery Clinic, and Jeff Morland, the chief executive officer of the Sports Surgery Clinic, who've been critical in understanding both groin pain and 3D biomechanics and their ability to work. This final slide gives you a Dropbox link to many of the papers. And also, please join this debate on Twitter. It's one of the best access points in order to debate both the papers as part of my weekly research review, but also as part of these talks, or on YouTube. Thanks for listening. I hope it's been stimulating.